I'm Dr. Judith Aberg. I'm Chief of Infectious Diseases for the Mount Sinai Health System and at the Icahn School of Medicine. I'm also the George Baer Professor of Medicine here. Thank you so much for having me today. So convalescent plasma and hyperimmune immunoglobulins are both prepared from convalescent plasma. So these are from patients who have had COVID-19, have recovered, and we've identified that they have high titers of antibody in their blood, and then we're able to collect this plasma that subsequently would be transfused into people who are sick with COVID. And these interventions have been used in the past to treat many infections when there was no vaccine or any drugs available to treat. Many of these infections you may be familiar with, like diphtheria, pneumococcal pneumonia, hepatitis A and B, mumps, measles, chickenpox. And these are all different conditions where we have shown in the past that convalescent plasma may be effective, as well as hyperimmuneglobulins. Now, convalescent plasma is generally thought to be very safe and well tolerated, but you can have sometimes adverse events can occur, and it has to be blood type specific. So symptoms that have been reported are similar to reactions that may occur with any type of blood transfusion, including having fevers, chills, allergic reactions. Sometimes it can be more serious transfusion related reactions that people get. Furthermore, in convalescent plasma, it's more than just the antibodies. It has other factors, including things like blood clotting factors, which may not be the best for people who are having COVID and may be already experiencing types of blood clots. So therefore, there's an advantage of looking at hyperimmuneglobulin. And essentially, hyperimmuneglobulin is taking that same convalescent plasma, but it's pooling multiple units together. And they do a process that we call fractionation, where they can actually extract and have the just purified antibodies, so the immune globulin G, that therefore contains a standardized amount of the antibodies directed to the organism SARS-CoV-2, the virus that causes COVID. So compared to convalescent plasma, hyperimmune globulins, it is not blood type specific, so it's much less likely that someone would have a transfusion reaction, although you still could have a reaction. And so that's important to remember, that you still could have an allergic reaction, or that there could be, just like with convalescent plasma, when you have a needle in your arm, you could have swelling or pain and potentially even an infection. The other advantage that hyperimmuneglobulin has is that you're preventing the transfer of these potentially harmful blood clotting factors I mentioned that are present in the plasma. So overall, again, when you think about hyperimmune globulin compared to convalescent plasma, it's prepared in a more consistent manner so that you can have more control over the amount and the amount of antibody concentration that is being given to you. So we have multiple research studies that we're going to be looking at. The first that needs to be done are studies that we call pharmacokinetic and pharmacodynamic studies. And what these are is studies that we can do that helps us determine what the appropriate dose and how often that hyperimmune globulin may be given. We are working with the National Institute of Health to be using the hyperimmune globulin products in their treatment trials, both for people who are hospitalized with COVID and people that are home, or what we call ambulatory, and able to go back home after they could get a infusion of the hyperimmune globulin. In addition, we're going to be launching a very large study to look at its use in something we call post-exposure prophylaxis. Now, this study will recruit about 500 patients across multiple sites across North America. And the intent of this study is to assess the efficacy of this hyperimmune globulin as post-exposure prophylaxis in people who are currently negative for COVID, but have had an exposure. So you may ask, who is that? So those are individuals who had a prolonged close contact with one or more individuals who turn out to have confirmed COVID. And we want to recruit these individuals 48 hours before they would have any symptoms. So 48 hours, within 48 hours after that exposure. So these may be people that you've had contact with who are not wearing a face covering or a face mask. It may be healthcare workers that are present in the room, and especially doing procedures that could be generating lots of aerosols that may put them at risk. It may be a household member or one of your partners who you've had a close contact with, meaning less than 6 feet, for a prolonged period of time. Or it could be that you're caring for somebody who has confirmed COVID-19 infection. So anybody who has had a really prolonged exposure to somebody with COVID could be eligible to go on this study. And hopefully what we would show is that patients who receive the hyperimmuneglobulin would have a decreased risk of acquiring COVID. This study will be done so that it's in what we call a randomized fashion. That's like a flip of a coin. And for every 5 people, 2 individuals will get the hyperimmuneglobulin at a specific dose, another 2 will get a different dose, and then 1 person will get placebo, which will be like saltwater saline that we normally infuse. And again, what we'll do is we will follow individuals doing frequent monitoring and testing over the course of 29 days to see if who may have acquired COVID, and again, to show that the hyperimmuneglobulin actually is effective in preventing that. Furthermore, we're going to be working with Emergent and the military for a pre-exposure prophylaxis study. So this would be one where you would have repeat dosing at a set interval. So this is to prevent you from getting COVID, not that you've had a known exposure yet, but that you could be at risk for having exposures. And so in this case, hyperimmuneglobulin, when you receive it, you're receiving antibodies. Those antibodies only last for a set time. So maybe 3 weeks or 4 weeks, and then you would need to be dosed again. So we have, as you can see, we have a really broad range of studies that we're really excited about that can help both prevent people from getting COVID as well as treat individuals who have COVID. So hyperimmuneglobulin is often viewed as a bridge until we have an effective vaccine. Again, as I just mentioned, hyperimmuneglobulin is infusing antibodies. A vaccine, you're given a substance, and it could be part of its RNA, DNA, a fragment. It is a substance that you would be injected with that triggers your own immune system to make antibodies. And it takes time for your body to make antibodies. So like in the study I just mentioned in post-exposure prophylaxis, there isn't time for a vaccine to work. So hyperimmuneglobulin would really be an effective use. And in fact, what we frequently do with other conditions is we use hyperimmuneglobulin in conjunction with vaccines to prevent COVID. So for instance, someone may have an exposure, as we just discussed, and you would want to provide immediate antibodies with that hyperimmuneglobulin, and then you would want to follow up by a vaccine to allow you to produce your own antibodies so that would last longer and give you ongoing immunity. And then there are people who may be allergic to components of the vaccine, and there are certainly people who do not want to take a vaccine. So while hyperimmuneglobulin most often is used as a bridge, there may be other conditions where we will continue to use, and in fact we would use all 3 of the therapies that I mentioned. That the studies are going to be ongoing, and while these studies are ongoing, as I mentioned, they will have placebos, and so some individuals may opt to receive convalescent plasma until we really have a licensed product that we can offer people, either hyperimmuneglobulin or vaccine as appropriate.